My name is Amanda Copenhaver. My patient is TM. She is a 59-year-old female who presents to Encompass Medical Group with complaints of left lower leg pain and swelling. She reports that 6 weeks ago she hit her left lower leg on the bed frame, and then later that day the dog pulled her down onto her right knee, scraping her knee on the concrete. She denies an actual fall or hitting her head at this time. Injury occurred 6 weeks ago. She reports that the right knee has been draining off and on since the initial injury. She reports bruising and swelling to the left lower leg that has gotten better with time. She presents today with concerns that there is still a knot below her left knee that has not gotten better since the injury. She takes 7 milligrams of warfarin daily. And over the last 6 weeks, she's been seeing a pulmonologist and has been taking oral steroids. Since being on the steroids, she's been having her INR checked every Monday. Last one was 4 days ago, and it was 2.2. She reports that since being on the steroids, she has noticed some bilateral lower leg swelling since being on the steroids. The left lower leg is tender to touch. She denies pain with movement or with walking. She has used ice and arnica gel to the site. She has been elevating the leg. She has not been wrapping it. She has not been evaluated for this injury. At this time, she denies fever, chills, shortness of breath, or chest pain. She states she'll be seeing her pulmonologist later today. Her past medical history includes atrial fibrillation and hypothyroidism. Her surgeries include left thumb surgery, tubal ligation, and a cardiac cath in 2011. Her allergies include sulfa and morphine. Her medications include 7 milligrams of warfarin daily, 100 mics of levothyroxine, and estradiol that she's applying twice a week as needed. Her immunizations are up to date. She recently had a flu vaccine. Her family history includes hypertension and gastric cancer for her father. Her mother has hypertension, and her brother has migraines. TM is a former 1-pack per day smoker. She quit 15 years ago, and she denies alcohol or recreational drugs. For review systems, TM denies fever or chills, changes in weight or fatigue. She denies chest pain, palpitations, shortness of breath with exertion. She reports mild swelling to the bilateral lower extremities since being on the steroids. She denies shortness of breath, coughing, or wheezing. She reports pain in the left shin. She reports that it's tender to touch. She reports that there's a knot below the left knee. She reports that there is bruising to the left lower leg from the knee to the ankle, and that there is a wound to the right knee. She denies headaches, dizziness, numbness, or tingling. She denies feelings of sadness or hopelessness, and she denies feelings of self-harm. She denies unusual bleeding or bruising aside from the left lower leg. Her vital signs include 138/92 for blood pressure, 88 pulse, 16 respirations, and 98% on room air. Her pertinent labs include the INR that was completed 4 days ago, and it was 2.2. On the physical exam, the patient is appropriately dressed for the weather. She answers questions appropriately and has a normal affect. She also has a steady gait. Her S1 and S2 is present without murmur. There's no swelling to the hands or feet. She has about 2+ edema to the left lower leg. Her radial and pedal pulses are 2+. Her lungs are clear to auscultation throughout bilaterally. She has a flesh-colored knot distal to the left knee. The area is tender to palpation, but there's no pain associated with movement or with walking. The left lower shin is tender to palpation. There's no tenderness to the posterior side of the left lower leg. There's no warmth or redness noted to the shin. Patient has full range of motion. There is ecchymosis noted to the left leg from the knot that's distal to the knee all the way to the ankle. And there is a an abrasion to the right knee, and the surrounding tissue is erythematous. The patient is alert and oriented ×4. She has a normal affect, and there is no unusual bleeding or bruising noted aside from the left lower leg. Our differential diagnoses for this patient includes fracture, hematoma, and thrombocytopenia. The H&P that led us to the conclusion of hematoma as the final diagnosis includes the injury that occurred 6 weeks ago, the long-term anticoagulant use, and the significant ecchymosis from the left knee to the ankle. The plan for this patient is to include an x-ray of the tib-fib to rule out a fracture. We also ordered an ultrasound to diagnose the hematoma, and we also went ahead and ordered a CBC to rule out thrombocytopenia. The treatment for this patient includes Keflex, 500 milligrams 3 times a day for the cellulitis of the right knee. The education for this patient includes that we will call her with the results of the ultrasound and the x-ray. We educated her that if it is diagnosed hematoma, it can take up to a year for the body to reabsorb it. Patient is advised to take her antibiotics as prescribed, take it with food, and make sure she takes all of it. We advised her to keep the right knee, the wound, clean and dry, and to go ahead and keep her appointment for her next INR check, which will be the following Monday. Patient is advised to keep her appointment with her pulmonologist. Otherwise, we don't have any referrals for her at this time. And we'll plan on seeing her in a month to make sure that she's starting to get better. For this patient, the curative factors for Jean Watson's theory, I would say developing a trusting relationship and cultivating a sensitivity to self and others were implemented here. The patient's injury occurred 6 weeks ago. She stated that all of it was starting to get better, except for the knot that was distal to the knee. The patient really was just a little bit anxious. I think she just really wanted a diagnosis and needed some reassurance. So establishing a trusting relationship and just listening to her and listening to her concerns, I think, goes a long way. Ordering the x-ray and ultrasound will help reassure her that there's nothing serious that's wrong. And I think we also use problem solving for decision making as well for the curative factors. Doing the CBC to rule out thrombocytopenia, and the x-ray to rule out fracture, and the ultrasound to make sure that it was a hematoma, I guess would be considered problem solving to make the decision for the official diagnosis.